raise that upper part of their airway and sort of open their airway and help them breathe, which is a maneuver you will see, or if you have rotated, you'll see many people do. The other thing that this also means is that when you're placing them to sleep, when you do the airway maneuvers like hyperextension of the neck, you probably obstruct their airway. So you need to maintain their airway in a neutral position. The other thing that we look at regarding their airway is their tongue being much larger. And the significance of that would be, Alex, what challenge do you face because the mouth is much larger than in proportion to the space in the buccal cavity? Alex N. Okay, if Alex wants unmute, Comfort. Comfort. David Jolly Moganzi. What's the significance of the child's tongue being larger compared to the size of the buccal cavity?
So I think this influences procedures like intubation.
In what way?
In that we have smaller space in the mouth.
Okay, good. What else? Leaving intubation aside, what else?
That's what I can think about.
What happens when you put them to sleep and you have given them anesthesia and they're not able to control their airway?
Okay, maybe the tongue can easily fall back and close the airway.
Good. So yes, so they are going to be prone to obstruction because you have a smaller space and a bigger tongue compared to that of an adult. Okay, thank you. And then their epiglottis. Significance of that, Alex N. Alex N. I'll go with Paddy. Looks like the rest don't want to participate.
Epiglottis of the baby is quite small since the airway is still small. So the hole entering the vocal cords is very small, so it is prone to edema. So
You've gone towards lower airway. First, let's stick to epiglottis only. Yes, their whole airway is small, but looking at the epiglottis only. What's the shape of the epiglottis and how does it affect, say, intubation?
I think the shape is kind of triangular. And it's very hard to open it.
So for them, their epiglottis is, so what happens with the epiglottis in pediatrics is that it's U-shaped and it's longer, so, and quite floppy. So when you are trying to intubate, you'll have the epiglottis fall in the way. That's why you most likely see people, or most times people use a straight blade so that they're able to carry the epiglottis along with them to be able to look into the airway. Thank you, Paddy. Then the other thing about their airway, their larynx is more anterior compared to that in an adult, and so you'll use maneuvers like a BAP, which is backward, upward, rightward pressure, or to try and push it more posterior, as well as placing a shoulder roll to try and get an axis. Then the other thing is that their airway is narrow. If we've had on the Hagen-Pasay equation, or if we have looked at it, you would see that when you decrease their radius by just one value, you're going to increase their resistance by almost 16 times, okay? So looking at the physiology of their airways, if you look at their thoracic cavity, for a child, a more developed, an older child, say 5 years and above, this is what you have for what their rib cage looks like. You have them moving anterior, their ribs inserting anterior inferiorly, as opposed to that in an adult. And so when they breathe in, you have this becoming more horizontal. And so what happens is, what this movement that we see is called a bucket handle movement. If you've paid attention to what they talk about when they're talking about breathing. So this bucket handle sort of creates an extra space. If you look at this image, sort of shows you a cross section. So when that child, when an older child or an adult breathes in, they can create space and increase their capacity, their lung capacity, as opposed to an infant for whom this is already fixed. So if you look at this shaded area, that's your abdomen. So for them, the only space that they can create is if you move this shaded region to the lower part. And as opposed to that in an adult, and if the abdomen moves, if they have the bucket handle movement, that's enough to create. And if they need a little more room, then they will have to move their abdomen down by taking in a much deeper breath. The significance is that the infant ends up being an abdominal breather. And if you have anything that impacts movement of this diaphragm or part of this abdomen back into the abdominal cavity, then you're going to impede respiration in this particular population. And so that's why they will use their abdomen to breathe, and they compensate for their oxygen use by increasing their respiratory rate. Okay, so I'll go to Elias. In what conditions would you be worried when you have an infant who, say, in what conditions do you usually see infants with distended abdomens? What did you ever see?
In liver disease.
Liver disease, okay. Which other ones? Which other ones? You've muted before completing the question. Someone with the name Camon 17, kindly unmute. Okay, let's see.
We also meeting.
Pardon? You see it in?
You see it in protein energy malnutrition.
Not so much. This tension that's impacting breathing. One where there, so what you see as B is showing you how the rib cage is and how much space or how much room they have when their diaphragm moves down. So if you look at this diagram, this diaphragm looks like it's already almost splintered. That's why even if you have any relaxation taking place, you're not going to have much of a difference as opposed to this that's already dome shaped. So not so much. So it's really anything that's going to increase your intra-abdominal pressure. So you have anything placed on their abdomen, you will impede their breathing because they are literally using the abdominal muscles to create any room for them to breathe. So anything in their abdomen, anything placed on their abdomen, you placing them on their abdomen to sleep, all those things will impact respiration in this particular age group. Okay, I see others in that chat. Anything in the abdomen. Yes, the child with Hirschsprung's disease will have something like that. If you have any abdominal obstruction. Timothy, you raised your hand. Kindly unmute yourself and ask.
Yes, so I didn't exactly understand how the bucket handle mechanism causes infants to be abdominal breathers.
You've mixed up the two. Bucket handle is in adults.
Oh, okay, so I didn't understand the whole thing.
Do you know how a bucket moves? Do you know what a bucket handle looks like?
Yes.
You've seen the movement when you move and you create a little more room as opposed to if you were moving it horizontally.
Yes, yes.
Okay. So if you look at the image on the right where the cursor is, that is the rib cage. That is how your rib cage looks like. So when you take a deep breath, or when you just during normal breathing for you, you have these ribs becoming more horizontal. So this moves up like this. So you're going to have space created both vertically and horizontally because you're going to expand outwards and upwards. Is that clear?
Yes, that is clear.
Yes. In a child, it's already horizontal. Okay. So they can only push outward a little, and then the other space is abdominal contents or the diaphragm to push downwards. That's the only space it's going to create. And this movement depends on the abdomen being able to distend, or for the diaphragm being able to push down on the intra-abdominal contents. If this is already occupied, then they don't have space to push. That's why we're saying that if you have obstruction, if you have anything impeding the movement or contraction of the abdomen, then it will be affected. They become abdominal breathers because they're literally depending on this movement to create space here. It's already sort of a fixed cavity for them. They have to depend on the abdomen to create any extra space for them to breathe. Is that clear?
Yes, it's clear now. Thank you.
Yes, you're welcome. Okay, any other questions? Okay, so anything that's going to take up their intra-abdominal space will impact their breathing. So that's something to think about if you if you find any child that has any intra-abdominal mass or raised intra-abdominal pressure or something that's any abdominal distension, they'll usually stop breathing because of that. And so it's something to think about and help them do. Okay, so something else about their respiratory muscles. In the infants, the abdominal muscles, the diaphragmatic muscles that they have are type 1 that easily fatigue So they will sustain any respiratory, they will not sustain respiratory distress. And for them, what will happen is they'll just stop breathing and become, so as long as you find a child who is in this, who has any form of distress, what will happen is they'll not compensate for long. They will stop breathing because they easily fatigue their diaphragmatic muscles, as opposed to the type that older children and adults have. They have type 2 that can sustain for a longer time, while the infants have type 1. Then in the infants, they have very compliant chest walls and very compliant lungs. So what happens is compliance is just about how much pressure change you're going to have, how much volume change you're going to have for a particular pressure that you give. So for them, you give and give air until they just burst because they're so compliant. The downside to this is any pressure exerted on them is going to easily compress or easily distend and cause barotrauma. So when you look at the lungs, because they're easily compliant, as long as you have a pressure drop, they close off their airways and end up with atelectasis, which is a challenge in this particular age group, and more especially the younger infants. Same thing with their chest wall. It's made of, their ribs are not yet calcified, so they have a lot of cartilaginous tissue even on their ribs. So they'll easily have atelectasis, which will impact or increase their resistance as they are breathing. Then also because of their compliance and easy atelectasis, they have a smaller functional residual capacity, and yet they have an increased oxygen consumption. So this predisposes them to hypoxia. This predisposes them to hypoxia and its effects. Then one other thing about their breathing is that whereas in an adult, when you have hypoxia in an adult, or you have hypercapnia in an adult or an older child, what happens is you're going to breathe much faster to try and compensate and take in more oxygen, or hopefully more developed brain or respiratory center in an infant. What happens is when there's hypoxia or hypercapnia, they will stop breathing, which will worsen whatever symptoms they have. So that's the other difference with their compensation. So in a nutshell, when you look at their breathing, their respiratory muscles are weaker. They already have a smaller capacity for their lungs and also cavity. Their functional residual capacity is smaller, and yet their response to hypoxia and hypercapnia is poor, and so they will not compensate. Instead, they'll stop, which will worsen the hypoxia. So what happens after, when you have anesthesia on board to their respiratory system? And your hand is raised, yes, please.
Thank you, Dr. Does that mean that in children it will be more easier for children to respond with bradypnea to hypoxemia with tachypnea?
You're breaking. I've not had anything.
Okay, I was saying that, does that mean that in infants, they respond in relation to hypoxia, they'll respond with bradypnea, and in adults, they will respond much easier to tachypnea in relation to hypoxia?
Yes, so adults are going to hyperventilate. Well, these ones, if you've noticed a neonate getting hypoxic, they stop breathing. If you've gone to the neonatal unit, or if you remember when you were rotating in the neonatal unit, usually they just stopped breathing. If you paid attention, or if going forward you pay attention, they'll stop breathing.
Yeah.
Hypoxic.
Okay, thank you.
You're welcome. So what happens with anesthesia on board? If you put a tube in, the tube you put in is usually much smaller. And so they're going to have a lot more resistance to breathe against, as opposed to the resistance that they already have. And remember, they're sort of, because of, if you look at how their physiology has been, if we go back to the previous slide, look at the respiratory muscles, look at the configuration of their chest wall, looking at their lungs, they're going to experience a lot more resistance, yet they're using the same anatomy to breathe against that. So that's something to keep in mind. So they'll tire easily. And so sometimes you have to keep ventilating them or giving them periods of assisted ventilation, okay, to try and help with that resistance. Okay, and then the other thing is when you give them the respiratory agents that we use, the drugs, both IV and volatile drugs, you're going to end up with depression of their centers, which are already working sort of prematurely. And so what happens is you end up with episodes of apnea. And the younger the child, or the younger the child, the more premature they are of apneic spells or apnea, even in the post-operative period. So that's something to keep in mind. Okay. So this is just a sort of something to explain the ways in which they end up with apnea. So they have more inhibitory reflexes, and then the other two that we've talked about. Okay. So looking at their cardiovascular system, so their cardiac output is 2 to 3 times that in an adult. Okay. And if you look at this table on the right side, that's looking at the heart rate. If you look at that in an adult and that in an infant, you would see it's almost 2 to 3 times. So when you look at the formula for cardiac output, you have it multiplied. So you have it as a function of their heart rate and the stroke volume. But when you look at just need someone, Alfred, kindly unmute and tell us about the ventricles in an infant or in a neonatal patient. In a neonate, sorry. Alfred? Someone called Elvis Tamale. Tell us about the ventricle. Alfred isn't unmuting, so Tamale. Is Tamale on the call?
Yes, good morning.
Good morning.
Yes, so I beg your pardon on the question.
Kindly tell us about the ventricles in a neonate. That's embryology.
I think a neonate has a bigger right ventricle than a left ventricle.
Is it bigger?
No, more muscular.
Sure. Are you sure? Patricia? Patricia? Okay, yes, Elias, you chose to go to the chart. Yes, they have poorly compliant ventricles. So what happens with them is because of having less of the contractile tissue or less of the of the contractile cells, they sort of end up having a fixed stroke volume, and so they'll depend on only their heart rate if they need to increase any cardiac output, or if they need to compensate for any oxygen delivery or any blood supply. They'll only have their heart rate to compensate for that. Okay. And that size when the child is born. So the other thing about their myocardium is that they mainly have parasympathetic innervation. So the significance of this is anything that would ordinarily cause a sympathetic response in the myocardium, for them is going to cause a parasympathetic response, which will be the bradycardia that you see. So any hypoxia, any episodes of hypoxia, laryngoscopy, hypercarbia, acidosis will all cause bradycardia, or will all cause a parasympathetic response that we see. So that's why they end up getting bradycardic. When you see a child getting bradycardic, it's not because whatever response or whatever stimulus it is that is being caused, that is affecting them is going down. It's because they're actually showing you that something has gone south in their CVS or whatever it is that you're causing. Okay. So looking at their immunity, their immune cells their white cells or their leukocytes are poorly developed. So mounting a response to an infection. There's someone whose mic is muted and unmuted. Okay. So mounting a response to an infection is very poor, and so they may not show signs of infection, or they'll show very subtle signs. Their clotting function is very poor. Okay. So as we all know, at the time when the child is born, they have higher levels of hemoglobin, and by that time they are a neonate, it has dropped to lower levels. Okay. And about 6 months, or sorry, about 3 to 6 months, you end up having what we call a physiologic anemia, as you have a transition going on. So in a newborn or in a neonate, the blood volume that they will end up with will depend on the amount of blood the amount of time between for cord clamping before they clamp the cord that allows the blood from the placenta to all go into the child, which is an important aspect because they will need a lot of blood in that time, and because of a poorly developed bone marrow, they're going to need that increased level of hemoglobin. Okay. So that time that they have that physiologic anemia, they're not going to have any issues because they still have a mixture of that too. They're breaking down the fetal hemoglobin, but they also have the adult hemoglobin that's forming, so they will still be able to survive. Then looking at their gastrointestinal system, generally their metabolism is poorly developed, and so they're at risk of the metabolic dysfunction disorders that we see, or syndromes if they have any, or the enzyme abnormalities that are seen, but then also that risk of hypoglycemia because they're not going to be able to. And then towards the end of the gestation period, usually about 35, 36 weeks, 34, 35 weeks, they deposit glycogen, which they use. And so once you have premature babies, they're going to have lower levels of glycogen, and that's why they are given. That's why they need to have dextrose. Then for children who are born to diabetic mothers or mothers who had gestational diabetes, they're going to have more insulin circulating. And so they'll be at risk of hypoglycemia because they have an increased level of insulin that's breaking down their glucose. Those are two things to note. So looking at this particular table, that children are usually given different types of milk. And the importance of knowing what type of milk they're on is because of their fasting time. So when you look at the animal milks and the formula, they have a lot more protein and what protein and fat compared to that which is in human milk. And so that impacts the amount of time taken for digestion. Okay. So you have a shorter time for digestion of human milk. So if a child, that's why if a child is only on human milk or breast milk, we give them what amount of time for fasting? Patricia. Patricia, how much time do we give a child who is breastfeeding before you tell them to stop if they're having surgery?
4 hours.
Is it 4 hours? If they're only taking breast milk? A child who is only taking breast milk, they're doing exclusive breastfeeding. Breast milk, no formula, just breast milk. Is it 4 hours? It's shorter than that.
2.
2? Not 2. In between there. 2 hours is clear fluid. It's 3 hours if you have a child who is only taking breast milk, because the breast milk, if you've looked at it, is quite watery and clear and it's easily broken down. Okay. I see 30 minutes, no, 1 hour, no, in that chart. Okay, so looking at their kidneys, their kidneys do not try to concentrate anything. So they will lose whatever there. And they because of the immaturity of their nephrons, they will not think like an adult's kidneys, or a child who is 2 years and older. Their kidneys, it will not think and say, oh, there's a lot more fluid, let me diurese, or there's a lot more salt, let me lose. What happens with their kidneys? It's going to work at the pace at which it works, and it will clear fluid and salts are in the same proportions, irrespective of whether there's a lot more salt or a lot more fluid. And their capacity to dilute to concentrate their urine is very, very low. So they'll keep losing salts. And what happens in that case is, if you overload a child, they get pulmonary edema, as opposed to an adult who will be able to diurese and lose that extra fluid much faster. So when you're giving them fluids, you need to be cautious about that, because they will not urinate it all at once. They will easily get pulmonary edema. And the other side to that is, you will know how much volume they have depending on how much urine they're passing out. So if they are dry, they will not pass urine. Okay. Then the other thing that happens in preterm babies is that they have more, they have a relatively increase the amount of aldosterone, which would translate to, what would that translate to, Patricia? Increase the amount of aldosterone will translate to? Mean you're calling?
They have a higher salt.
Okay, good. They'll have a higher salt. So what do you think that would mean when you're giving fluids to these babies? If they're keeping more salt, kindly specify which salt. Patricia, back to you.
Hyponatremia.
Okay, so they'll have hyponatremia. So what does that mean if you are the intern or the specialist with this child? What kind of fluid would you want to think about giving them?
Fluids with less salt.
Okay, like which ones have you seen on the ward?
Ringer's lactate.
Okay, what else? Which other ones have you seen that the people use? Patricia? Okay, we'll go with Godfrey. So which other fluids do you know? Godfrey, which other fluids apart from Ringer's lactate? Dextrose would help us with the glucose. What other fluids? What crystalloid would you want to give if it's not Ringer's? Since you definitely don't want to do saline. Joseph, but we've said that the patient, the baby is at risk of hyponatremia. Yes, Jonathan?
I might use half strength Darrow solution.
Okay, half strength Darrows would be your other option. Okay. Okay. So that's what you want to think about when you're giving fluids to this to neonates or to infants. But by the age of 2, they've usually developed the number of nephrons that are similar to that of an adult, and their creatinine clearance is almost at adult levels. So looking at their total body water, if you look at this graph, in the earlier, in the first, say 3-4 months, you usually have, in the first 1 year of life, you have a raised total body water that sort of goes to adult levels by about 2-3 years, which is about 65 to 70%. Okay, and that, if you look at their extracellular compartment, they have a lot more fluid in their extracellular. That's your interstitial space and your intravascular spaces that make up your extracellular compartment, as opposed to their intracellular compartment. Okay, the significance of this is any loss of fluid. Okay, 2 things. One, when you're looking at their total body, their volume of distribution of drugs, if you have drugs that are more water soluble, or when you give them intravenous drugs, they have a lot more water, so you'll see us go for higher doses of those drugs because of the increased volume of distribution. You have a lot more water in their body, and so they're going to do what? They're going to sort of have a dilution effect of these drugs if you give them at the same doses as in older patients or older children. And then their extracellular compartment having a lot more fluid means that they'll lose more water. They'll lose water much easily and get at risk of dehydration, because most of this fluid we'll see is lost through the non-essential losses and their very porous skin. Okay. Then the other thing about looking at their skin is that their temperature regulation is poorly developed, and so they have more brown fat, meaning they're going to create heat through metabolism, which is what we call non-shivering thermogenesis, as opposed to shivering, which is really limited for them. Okay. And so they'll still have risk of hypothermia. And then their larger surface area to volume ratio, and yet you have a poor skin with less subcutaneous fat, which is quite porous. All those will increase their risk of hypothermia. So the precautions you want to take when you have such a child are, if you have such a child in a room, Hilary, what would this translate to? Knowing that they're going to easily lose heat through their skin, which is quite porous, and they're not going to shiver to try and generate heat. And yet they have a larger surface area to volume ratio. Hilary? Okay. Isabelle, kindly unmute and tell us what you would do to try and prevent this from happening in the event that you're working on you have a child that you're working on.
Hello.
Hello. Yes, Alex has already mentioned a warming mattress and a warm OR. So you can tell us something else apart from that.
I think I will ensure the room temperature is slightly higher.
Okay, slightly higher or at the same temperatures. Then what else would you do? Someone already mentioned the room temperature. So what else would you do apart from warming a warming mattress and a warm theater? What else would you do?
Covering the baby.
Okay.
Yeah.
Mwanje? Okay, warm fluids. Okay.
I could also think of forced air warming.
Okay,
system.
forced air. Okay, so all those, yes. Okay. Nabunga. You have your hand raised up, sorry.
Yeah. Good morning, doctor.
Good morning.
My question goes to the current slide. We are saying infants are prone to hypothermia. Why is it that
I can't hear you. I don't know if it's your network.
have more brown fat? I need to know. I need clarity on why we say that hypothermia is, infants are prone to hypothermia, yet we are again saying they have more brown fat, and provided that brown fat is oxidized to generate heat. So
okay, so for them, what happens is they're going to produce heat by just metabolism. That's all. They're not going to be able to have the muscle contraction bit that comes about because of shivering. They're not going to have that in addition to this. So that's the only way they're going to try and generate heat for them. And yet you have all these other things that are working against them. So despite being able to produce heat by their brown fat, they're still going to they're still going to lose heat because they have a poorly developed thermal regulator. They already have a larger surface area to volume ratio. Their subcutaneous fat is much less. So that's going to work against them despite an attempt by their body to generate heat. So they won't have the muscle contraction that we call shivering to sort of try and generate heat or prevent blood flow to the skin and therefore heat loss. That's what happens. Someone had their hand raised up. Okay. Is that clear?
Yeah, it was me, Dr. Hadman. I wanted to explain that the fat cannot offset the magnitude of the heat loss, so it does mean that you will not feel warm.
Okay, got it. Thank you. Okay, any other questions regarding this? Okay, so we'll move to the next slide. So, still looking at their physiology, their CNS is quite their blood-brain barrier is easily broken by things like hypoxemia or any decrease in blood supply, and so that increases their risk of cerebral edema, which will end up increasing their risk of which will end up increasing their intracranial pressure. But then also in preterm babies, the bilirubin that's water soluble is going to easily cross and will easily cross if you have it easily broken, and so you end up with increased risk of kernicterus, especially in this particular population. The other thing about the CNS, there's one question that's asked about anesthesia and the developing brain that we can't leave this discussion without talking about, and it's a debate. If you go and Google things about anesthesia and the developing brain, the different studies that have been done. But what the bottom line of it is, yes, there probably is an impact or an effect that we don't know about. Some show a bit of developmental difficulties, which are not so pronounced really. So it's still a debate and a controversy on whether it does impact a developing brain. And if a mother asks you one of those questions, it's about telling her there might be an effect that is not known, but you need to weigh the risks of having surgery or the benefit of having surgery versus the risk of either developing something that's known or not known. So it's really a gray area that is there, but there's questions about whether it does impact the developing brain. What's in literature is shorter surgeries, usually less than an hour, were not impacting development. And then also the number of times. So it's really a debate that you need to have in mind when you're looking at these children. If you're sending them for surgery, you want to think about whether it's really beneficial at that age, or they can wait until they're much older, say 2 years or 5 years even. Okay. So regarding their pharmacology, as we already said, their renal function is poorly developed. Their hepatic function is also poorly developed. So that means that you're going to look at the drug doses that you're giving, and some of them are going to be higher or lower, depending on the development of, depending on the clearance of the drugs and also and their metabolism. Okay, so drugs that have renal clearance you might need to give higher doses because they're going to be eliminated much faster. And then those that may not be impacted by that, you might give normal doses. Then because they have a greater total body water, drugs that are more water soluble will need, you need to give higher doses because of that increased volume of distribution. Then because they have poorly developed hepatic enzyme function, drugs that are metabolism, like which ones? Need someone to tell me. Collins, which drugs do you know of that you've seen in anesthesia that undergo hepatic metabolism? Collins? Okay, Keith, kindly unmute and let us know what drug.
Drugs like morphine. Like morphine.
Okay, like morphine. Which other ones do you know about?
Someone has mentioned paracetamol.
Okay, but local anesthetics, especially the amide ones, will so you're going to have increased risk of drugs that undergo that. But drugs that are protein bound, because they have less effect, you're going to have an increased sensitivity or a seemingly increased sensitivity to those drugs, and therefore increased risk or likelihood of toxicity because of these particular drugs, either to the drug itself or to its metabolite. Okay. So in conclusion, looking at their looking at, you want to remember that children are not small adults. Their airway is different, their breathing is different, their respiration is different. Their cardiovascular system works in a different way. Everything to do with their GI, especially the hepatics, do work differently from that in an adult. Their immunity, their hematology, their immunity, their coagulation process is different. The way their renals process toxins is different. Their brain is still developing, so you want to do things that will not be deleterious to their development. And the way their pharmacokinetics is also different. So you don't look at them as an adult packaged in a smaller container. They are actually different individuals. Okay, so I hope we're still together. As we look at the other five things, so we'll look at preparation. Okay, so preparation, as Benjamin Franklin once said, if you fail to prepare, you're definitely preparing to fail. Okay, so preparation regards what we've been talking about for the past probably 1 hour. Okay, so as you're doing their preoperative evaluation, you look at their physiology. What we discussed was what should be normal for those children. And so once you know the normal, it should be easy to tell what is not normal. Okay. So as you're preparing and they're fasting, so the current guidelines are actually recommending up to 1 hour before surgery. Other places are even doing 0 hours before surgery, but it is clear fluid. And what do we define? You do 3 mL of clear fluid up to 1 hour before surgery. Okay. Keith, what do we term as clear fluid? What would you tell the mother is clear fluid? What instructions would you give a mother who is fasting her baby? Keith, what would you define as clear fluid?
Clear fluid is that has the same density as water. It might not be necessarily clear, but clear as in the sense of the word clear, but as long as it has the same density as water.
Okay, so how would you explain that to a mother who has never gone to school? Or how would you explain that to a nursing assistant on the ward who is helping you out with preparation of the patients? Would you tell them density? Okay, yes.
Light fluids. It can be tea, it can be.
Okay, someone has already put it in the chat. It's something that you can, if you put a print across, so if you put newspaper print, any writing across, you'll be able to see the writing on the other side. As long as you're able to see that, then it is a clear fluid. Okay, so it's recommended up to 1 hour before surgery, and it helps with, you have a patient who is less irritable, they are happier, they're less cranky, and their hemodynamics are definitely much better. Okay, so it's fluid up to 1 hour before surgery. So that's what you do in children. Then the others, 6 hours, 4 hours, 3 hours still remain the same. Clear fluid has just been shortened to 1 hour. That's what the current guidelines from the Association of Paediatric Anesthesiologists, Anesthetists of Great Britain and Ireland, which is this in full. So pre-medication is really individualized, okay? And it's an ongoing debate of whether you really need to give them, use pharmacological agents to do their pre-medication, okay? What's usually done is this, for their anxiolysis. So the level of anxiety, which is a big thing that people don't like about pediatric anesthesia, the anxiety levels that the guardian or the caretaker has. And also the anxiety levels that you'll see depend on the age. So younger children, by the less than 6 months, you usually not know what is happening. Though there are some at 4 months you would be able to see or would be having stranger anxiety. So depending on their age levels, you will use different therapies to try and help them. Okay, some of them will be at a higher risk depending on their environment, depending on developmental disabilities they might be having. Children might have anxiety levels that are much higher, even at an older age. You'll probably find a 10-year-old autistic child who will be more anxious compared to an ordinary 10-year-old. Okay, those are things to keep in mind. And also how you work on their anxiety will be different. So for them, non-pharmacological methods might work, okay? You might choose to come in peace like this one. So this, what you see in the corner, the picture is not having Africans because we are yet to do it in our setting, but this is what's usually done. They have play therapy. So they usually have someone come in days before or a day before the surgery and have the child sort of go through. So this is depending on the child and level of development of that child, okay? And help the child prepare for the surgery and sort of create a more familiar environment so that when they get into the theater, they're less anxious. For a child like this one crying, you probably won't be able to do this, but you might have their parents come in, okay? Like this one, this is probably the father of the child coming in with the child as she sleeps off, okay? Other things that are done are they usually have play therapy. They have masks that come in their favorite cartoon characters. Those are all to help with anxiety. And the reason this is pushed for is because these episodes of anxiety or these episodes of separation or this stress usually translate into mental health issues much later in life. And so that's why you want to prevent it and not be the cause for something like that. Okay. So this just shows, summarizes what you can be able to do. You'll look through them later, but it shows what you can be able to do, what interventions you can be able to do, and regarding the different ages or specific for the different ages. So even regarding preparation, you look at you want the appropriate equipment for their age, for their size, for their physiology, the appropriate drugs for the procedure, for their size, for their weight, for their physiology. I can echo this time and again. And when you're looking at the plan, the best plan is the safest plan and always beautiful plan that you'll use for them, okay? And sometimes the most beautiful plan might be referring them to a better facility, okay? I know by now all of you are very exhausted. Finally, we'll look at pain management, okay? So quick question, the best way to manage the pain is either to avoid it or to wait for it to happen and manage it. Elijah.
To manage it.
Good morning. Is it to avoid it or to wait for it to happen?
To avoid it.
Okay, to avoid it. And the best way to okay. So there are things that usually cause pain that we don't think about, like pain when drawing, pain from the multiple IV insertions, trying to get an IV line, trying to get blood samples, pain, and then that aside, the pain from the actual procedure. So all those are going to cause pain. Okay, there's a study that showed that children who had been in the NICU for some months, and because who had been in the NICU for some months, usually they are going to get pain from pricks from blood draws or pricks from cannulation. They associated any movement with pain. So they would cry even when they were just having a nappy change, having a diaper change, because they associated any procedure with pain. Okay, so you want to mitigate pain from things like that. Okay, even when you are, so for their pain, you're going to use, there are scales that are used to assess pain in those particular age groups. Things like the FLAC that looks at the facial expressions, and then their level of activity that also relates to their level of development. So when you're assessing their pain, or you can use a visual analog scale and your numerical rating scale, that's all depending on their level of development. So a 5-year-old in an urban setting might be able to rate their pain using a numerical scale, while a 10-year-old in a rural setting may not be able to. So you'll have to use a visual analog scale for them. So when you're assessing their pain, you want to get an age appropriate or a developmental level appropriate scale when you're assessing their pain. And looking at the modalities to manage their pain, the systemic ones, where we have all the IVs, and then the regional ones. A multimodal approach is definitely preferred for managing their pain, especially if they're coming for a surgical procedure. Okay, this image is just to highlight that regional anesthesia is also used in this age group, and because of the risk for some of them, ultrasound may be used to help give a spinal anesthetic in them, so that you don't damage their spinal cord. Okay, so regional anesthetics are also given. So there are regional blocks that can be given for them, keeping in mind the pharmacology of their medicine that you're giving, and the physiology and their physiology in terms of metabolism. And then also other modalities that can be given, the spinal, the caudal that you'll commonly see. If you're lucky, you'll see a spinal being given in them. But then the caudal that's commonly used, then particular limb blocks that are also being studied, and their efficacy in this particular age. Systemic drugs are also given depending on their development. So paracetamol, opioids, NSAIDs not so much, but older infants might get a bit of NSAIDs being given to them. Then the alpha-2 agonists, those are also being studied in this particular age groups for managing their pain. But all in all, for most, it's a multimodal approach. Ketamine is also used in these age groups. You can't afford to leave it out. Yes. So their pain management is also one important thing to think about. Any questions? Don't have any questions coming in, we'll conclude with this. Yes, Daniel, you have your hand raised up.
Morning, doctor. So going back to the slides on the respiration, the lungs, you said something about the FRC and some questions. So for children who have, I think you said they have a low functional residual capacity.
Mm-hmm.
I think, so when you're giving these inhalation anesthetics, what exactly do you follow to give them that it's low? Are you going to increase?
What exactly do you follow to do?
To achieve anesthesia.
Mm-hmm. Are you going to increase what?
Increase the amount of gas given? Increase respiration.
It's not the amount of gas. So what determines
You're working, I can't hear you.
What is it that a patient is going to sleep? What is it that determines the rate of the speed of induction when you're using inhalation anesthetics?
The factors that would affect the drug uptake, like
Let's use inhalation anesthetics only. Okay. Solubility, what else?
Flow, pulmonary alveolar blood flow.
Okay. You're breaking.
The age of the patient.
A little, not so much, but okay. So what you've mentioned, from what you've mentioned, children have at least one of those. Okay. Higher. Someone keeps calling. I'm saying, so their pulmonary blood flow is increased. Okay. So they're going to have a higher uptake of whatever drug you're using. That's why they're going to sleep much faster. Their respiratory rate will also increase the uptake of that drug. So it's there. So that the significance of the functional residual capacity is not for the drug being for an inhalation anesthetic. That reserve, that functional reserve is really for your oxygen, your extra oxygen that you take in. Significance comes in when you're just oxygenating. When you're not actively oxygenating this patient. Okay. When you're not mask ventilating this patient, how much time do they have because of an extra reserve of oxygen? For them, because they have a smaller capacity, they're going to get hypoxic once you stop. They're going to desaturate much faster once you stop giving them oxygen, because they don't have a reserve from which the lungs can pick, or from which the blood can get some oxygen in the time that you're not giving them oxygen actively. That's what the functional residual capacity is for.
Okay, and my other question was regarding the heart rate. We talked about how there. So one of the lectures, they talked about giving atropine.
Okay.
Together with one of the anesthetics. I don't remember. And is that related to what we talked about, the heart rate in children, like to help the heart rate pick up?
So atropine, which lecture was that? Was it to do with muscle relaxants?
I don't remember, to be honest. But it was something about the cardiac output in children and how it's affected mostly by heart rates.
So have you understood where it's coming from, or how cardiac output is affected? Okay. And remember, their innervation is mainly parasympathetic.
Yes.
Okay. So for some people, because of that impact, because of initially the knowledge was we have more parasympathetic, so they were only giving that, but no one thought about what would predispose them to the parasympathetic innervation taking place, having that parasympathetic response, like the bradycardia. Okay. So if you know the things that are going to cause the bradycardia, you may not necessarily need to give it to every patient. Or if you already see they're getting bradycardia, that's when you might need to give them a parasympatholytic like the atropine. But it's because of that. So some people will give it every time they're working on a child, but you don't really have to. If you know that my laryngoscopy is going to do this, then you want to make sure they're deep enough so that you're not going to cause that response. So you want to prevent that vagal response. Answer your question?
Yes, you do.
Yes.
Okay.
So that's what happens. Okay.
Thank you.
You're welcome. Jonathan, your hand is raised.
Yes, thank you so much. My question is still related to the heart rate. So when for a neonate whose heart rate might be pretty higher than an adult, when do we say that senior unit might be having a cardiac arrest? Will it be at around 50 beats per minute or lower than that? And anesthesia.
What is a cardiac arrest?
Cardiac arrest would be a situation whereby the heart rate, there is no heart rate at one moment for probably more than 10 seconds or 15.
What's the definition of a cardiac arrest?
I don't have a full-time definition of it.
What do you understand by a cardiac arrest?
A cardiac arrest is when the heart, there's no heart rate, or the heart stops beating for probably more than a particular, let's say more than like 15 seconds.
Okay. And usually you're going to have hemodynamic, you're going to have a cardiovascular collapse. That's when you say you have actually arrested.
Okay.
Okay. So it's going to be translated into that. So for them, I see someone in the chat. So when they get to bradycardia, when they get to a bradycardia of less than 60, usually you're going to resuscitate because 60 is really low for them. Okay. So when you have a neonate getting to bradycardia, then you're going to say this patient has arrested. Okay. They've had a bradycardia. Then the other things that you'll see with the arrest are the other rhythms that we see with cardiac arrests. Okay.
Okay.
Yeah.
Right, thank you.
You're welcome. Any other questions? Okay. So if we have no other questions, with pediatric anesthesia, you can choose to have one of these. You could actually have one of these. And the one on the lower part is what I hope we'll all be aiming for, which is a possibility. Very, very possible that you can strive for. Yeah, we'll call it. If you have any other questions, you'll just send them through Paddy or send them to my email. I would like to end this. Have a good day. Let's meet on Friday at 6:30 for the lecture on sepsis.